grateful presentation. First, we'll have Dr. Tripti. Sorry, please. Virendra Kumar Jha. Please come on the stage.
Good morning everyone. I am Dr. Virendra Kumar Jha, Microbiology Department, NMCH Patna. I am going to presenting topic on comparison of CVNet and ZN stain with culture on LG media for diagnosis of pulmonary tuberculosis. Introduction. Tuberculosis is a major airborne communicable disease. The infection is acquired through inhalation of droplets containing Mycobacterium tuberculosis. Bacillus typically affects the lungs, causing pulmonary tuberculosis, but can also affect other sides of the body, leading to extrapulmonary tuberculosis. According to WHO, in 2019, 10 million cases of tuberculosis globally, both gender, more than 15 years. This accounted for 56% of all cases. Mycobacterium tuberculosis is small, aerobic, weakly gram-positive, non-motile acid, fast bacillus. High lipid content of this pathogen, many unique clinical characteristics. It divides every 16 to 20 hours, which is extremely slow rate compared with other bacteria, which usually divide in less than an hour. Transmission pulmonary tuberculosis through cough, sneeze, speak, sing or speak. They expel infectious aerosol droplets 0.5 to 5 micrometer in diameter. A single sneeze can release up to 40,000 droplets. Each one of these droplets may transmit the disease. Primary site of infection in the lungs, known as Egon's focus, is generally located either upper part of the lower lobe or lower part of the upper lobe. Tuberculosis classified as granulomatous inflammatory disease. Macrophage, epithelial cells, T lymphocyte, B lymphocyte, and fibroblastic aggregates to form granuloma, with lymphocytes surrounding the infected macrophage. Macrophage dendritic cells in granuloma unable to present antigen to the lymphocyte, thus immune response is suppressed. Another feature of granuloma is development of abnormal cell death, necrosis in the center of tuberculosis. To the naked eye, this texture of soft white cheese and is termed gaseous necrosis. Diagnosis: tuberculosis on the basis of constitutional symptom lasting longer than 2 weeks. Chest X-ray, morning sample sputum for ZN stain, and multiple sputum sample cultures for acid fast bacilli at the initial evaluation. Nucleic acid amplification test and adenosine deaminase testing may allow rapid diagnosis of tuberculosis along with routine blood test. Tuberculosis prevention control efforts rely primarily on the vaccination of infants and the detection and appropriate treatment of active cases. The only available vaccine is Bacillus calmette urine BCG. The CBNet has two key advantages over conventional microscopy for the diagnosis of tuberculosis. First, more sensitive for pulmonary tuberculosis, and second, it can detect RPUB gene mutation that confer rifampicin resistance. It is considerably more expensive. CBNet is polymerase chain reaction based method for detection of TB. It is a MTV specific automated cartridge based nucleic amplification assay having fully integrated and automated amplification and detection using real time PCR, providing results within 100 minutes. It has a highly specific primer and 5 unique molecular probes to target the RPUB gene of Mycobacterium tuberculosis, which is critical gene associated with rifampicin resistance. LG media is selective media specially used for culture of Mycobacterium tuberculosis. Grow on Mycobacterium tuberculosis appears as brown granular colony, buff, rough and tough. The media must be incubated for significant length of time, usually 4 to 6 weeks, due to slow doubling time of tuberculosis, 15 to 20 hours compared with other bacteria. This type of analytic study is comparing CBNet and ZN stain with culture on LJ media in diagnosis of pulmonary tuberculosis. The study helped in early diagnosis of pulmonary tuberculosis and thus by reducing the morbidity and mortality of the disease. A study done in Nalanda Medical College, Patna. Analytic study was carried at 150 sputum sample. These samples were collected from patients clinically suspected with pulmonary tuberculosis. and no past history of ATT. Patients presented with fever, chronic cough, sometimes blood sputum. Other common presentation: weight loss, loss of appetite, and occasional chest pain. All 150 samples were subjected to ZN stain, CBNet, and culture on LJ media. Simultaneously compared with respect to sensitivity, specificity, positive predictive value, and negative predictive value. Then sample size on the basis of randomization, sample size 150 patient. Inclusion criteria: clinical features history of pulmonary tuberculosis with written consent, pulmonary tuberculosis having one or more risk factor, patients with clinical features history of tuberculosis but not receiving ATT. Exclusion: patients not giving consent and patients clinical features history of other than tuberculosis, prolonged history of chronic cough or other illness like COPD. Materials and methods in this study: sputum culture and LJ media of suspected case of pulmonary tuberculosis, CBNet for isolation of acid-fast bacilli and deformities in resistance cases, ZN staining of sputum. Sample collection: morning sputum sample were collected in clear plastic leak-proof and wide-mouth screw-tight sterile container. A morning sample collected on 3 consecutive days. Asked the patient to cup sputum directly into wide-mouth sterile container. Proper labeling of container was done, such as name, age, sex of patient, registration number of OPD or IPD. ZN stain technique: prepared from thick mucopurulent part of sputum. Smear was fixed by moving the slide for 3 times over flame burner, then covered with carbol-fusin for 8 to 10 minutes. Then decolorization was done, 25% H2SO4 washed with plain water, and then counter stain was done with methylene blue for 1 minute. Slide was visualized under while immersion microscope, 100 times magnification. Each slide observed for every 10 minutes corresponding to 300 field was examined. Culture is gold standard method for detection of tubercle bacilli. It detects as few as 10 to 100 bacilli per ml of sputum. Sputum was inoculated in LG media aerobically 37 degrees Celsius for 6 to 8 weeks due to long generation time. Cultures was examined first 4 days and then after weekly till 8 weeks. In positive case, colony of microbiome tuberculosis was seen. Cartilage sputum liquefaction and inactivation was done by adding a double volume of sample reagent 1:2. Then mixture was a second for 10 to 20 times. After that, mixture incubated for 10 minutes at room temperature. Again, second vigorously for 10 to 20 times. Again, sample was incubated at room temperature for an additional 5 minutes. Using press transfer pipette, 2 ml of processed samples transferred to the cartridge. Cartridge are loaded into instrument as per instruction given. Total 150 samples subjected to ZN stain, CBNet and culture. Then culture and CBNet, correlation between ZN stain and culture: out of 150, 54 acid-fast positive. All of which show growth on culture. Among 96 acid-fast negative sample, 25 show growth on culture and 71 negative. Then AFB smear and CBNet, out of 150 sample, 54 AFB positive, all of which also CBNet positive. Among 96, 29 CBNet positive and 67 CBNet negative. Then CBNet and culture. In 150 sample, 83 CBNet positive samples, 8 were culture negative. Among 67 negative, 4 were culture positive. On the basis of the CBNet results, sputum sample show sensitivity of 100%, specificity 88.7, PPV 90.3, negative predictive value 94%, whereas culture and LJ media show sensitivity 68.3, specificity 100%, positive predictive value 100%, negative predictive value 73.9%. CBNet has a very high sensitivity in comparison to ZN staining for tuberculosis. On the other hand, ZN stain is highly specific, 100% for detection of acid-fast bacilli. Then discussion and conclusion. Purpose of this study to evaluate the diagnostic yield of CBNAT to detect mycobacterium tuberculosis in a sputum sample. Culture remains the gold standard. All the growth can take 6 to 8 weeks. Molecular method is a rapid diagnostic tool for both smear negative or positive clinically suspected TB. It also gives information about rifampicin resistance. This is beneficial in treating patients with multi-drug resistant TB and TB-HIV co-infection. Conclusion: on the basis of this study, conventional direct microscopy is rapid and inexpensive but far more sensitive for diagnosis of TB. It gives no information about viability of organism. Whereas CBNAT is very useful for the early diagnosis of TB with reliable result. It also gives information about rifampicin resistance. Its major disadvantage, besides its cost effectiveness, is that it cannot differentiate between active and cured TB.
Can you tell one stain other than leaden stain for
Rhodamine or
any other methods of microscopy rather than traditional microscopy?
fluorescence microscope. Thank you, sir.
See, I'll give you one suggestion. Okay, your presentation was good. Congratulations. You're doing a PG paper presentation, right? So in the introduction part, you could have skipped giving so much details about AFP procedure and all that. Everyone knows that. You wasted some time doing that. Rather, you should have focused more on your results and all that. Okay, thank you.
One question. Say something on the diagnosis of the intestinal. How will be the accuracy of the
Mike Donald?
You heard the name of the common person?
टाइम वाला ठीक है.
Can we have Dr. Nebha on stage?
Good morning, everyone. I'm Dr. Nebha, third year PG, Department of Biochemistry, Sasaram, Jammu. I'm going to present electrolyte imbalance in a patient with acute ischemic stroke. Ischemic stroke and transient ischemic attack are common cerebrovascular disease and associated with high disability and mortality rate. The World Health Organization has reported that approximately 15 million people suffer a stroke annually, of which 5 million are fatal and 5 million result in a permanent disability. Identifying and controlling the stroke-related risk factor would be extremely important in the treatment and secondary prevention of stroke. Electrolyte disorder as a complication of dehydration, diabetes, renal failure or myocardial infarction are frequently observed in a clinical practice. Hypokalemia, hyponatremia, hypokalemia and hypocalcemia were common electrolyte abnormality encountered in a clinical practice. Ischemic infarction or hemorrhage in the brain lead to a state of non-convulsive focal neurological deficit of abrupt onset known as stroke or cerebrovascular accident of Out of all neurological disorders, CV is the most debilitating and is ranked as a third leading cause of death. According to the World Health Organization, the mortality due to stroke account for approximately 85% in developing countries. The incidence of stroke has declined in the Western population during the last 3 decades. On the country, the burden of the disease in the South Asian countries such as India, Pakistan, Bangladesh and Sri Lanka is likely to be rise. Electrolyte disorder are commonly found among the other metabolic problem in a patient with acute ischemic stroke. It is a potential cause of patient death unless corrected promptly. The disorder of sodium and potassium balance are identified as the most common electrolyte abnormality in a patient with acute stroke. Patient with hemorrhagic stroke present with symptoms like headache and vomiting, which in turn is a potential cause of electrolyte imbalance. This disturbance in the electrolyte balance is due to dearrence secretion of antidiuretic hormone, rise in the level of arterial and brain natropeptide, and inappropriate fluid input and output, causing complications like seizure and death. Therefore, in order to prevent morbidity and mortality in HCV patient, early diagnosis of electrolyte imbalance is important. Presently, the data available about the prevalence of electrolyte disturbance in a patient with stroke are not enough essential for developing country. The purpose of our study is to determine the frequency of occurrence of electrolyte imbalance in a patient presenting with acute ischemic stroke. Methodology. The study is a descriptive cross-sectional study conducted in the department in the year 2021 to 2022. Total 200 patients aged between 30 and 85 with either ischemic or hemorrhagic stroke, as seen as a CT scan or seen in a CT scan or MRI of the brain were enrolled in the study. Diagnosis was made by neurologist. Conservative convenience where non-probability sampling was used. Patients with chronic kidney disease were excluded from the study. Informed consent were taken. Statistical analysis were assessed with using mean standard deviation, chi-square, and was considered significantly only if the p-value is less than 0.5. As result, age group by distribution less than 50 years, frequency is 25%, 12.5, 51 to 60 years, frequency is 78, percentage 39%, 61 to 70 years, frequency is 20, percentage 11, 71 to 80 years, frequency is 57, and the percentage is 28%. More than 80 years, frequency is 18, and the percentage is 9. Total patient is 200, percentage 100. Hemorrhagic stroke, frequency 93%, 46.5. Ischemic stroke, 100, frequency is 100 out of 200, and percentage is 53. Hemorrhagic stroke is in dyselectrolemia, absent in 35%. Present in 58%. The total is 93. Ischemic stroke number is 72 absent, 35%. Total is 107. Discussion. Stroke is the third most common cause of death in developing nation after ischemic heart disease and cancer in developing country. Maximum patients were found 50 to 60 years age group, followed by 61 to 70 years age group. In this study conducted by Hassan H. Musa, the common affected age group was between 41 and 60 years, followed by age group 61 to 80. Bodyard et al. Indicated that stroke is more prevalent among men than women, with ratio varying from 1.3:1 to 2:1. In the present study of 50 stroke patients, 25 had dyselectrolemia. The study conducted by Hassan M.K. 70% of all patients with acute stroke had electrolyte disturbance. In the present study, 34.7 hemorrhagic stroke patient had dyselectrolytemia in comparison to 70 ischemic stroke patient. The association with the type of stroke and dyselectrolemia was statistically significant. The study conducted by Mudar R. Siddiqui of total acute stroke patient had dyselectrolemia 62.2% of acute hemorrhagic stroke and 43.3% of acute ischemic stroke patient had dyselectrolemia. Association between the type of stroke and the serum sodium level was statistically significant. In our study, serum and pleural potassium electrolyte, chloride and potassium bicarbonate were not statistically significant. This was similar to the study conducted by Sun, which had prevalence of hyponatremia, ischemic strokes. Conclusion: incidence of hyponatremia was relatively higher in ischemic stroke as compared to the other electrolyte. Close monitoring of serum electrolyte must be done in all patients who were admitted with stroke in order to promptly manage and decrease the mortality rate.
माइक ऑन किए ना सर, माइक ऑफ है.
You are studying hyponatremia. In any instance, hyperkalemia, you will compare hypo or hypokalemia.
In my study, sir.
Yeah.
Hyponatremia is significantly more in ischemic stroke, where hypokalemia is in hemorrhagic strokes.
Thank you.
Thank you, sir.
Dr. Tripti.
Dr. Nishant or Amish Kumar Pandey, is they are available? Dr. Nishant, Dr. Ashwini Kumar Pandey? No. Okay, Dr. Tripti, who will start your presentation?
Good morning, sir. Topic of my presentation is hematological and chromosomal analysis of siblings having Fanconi anemia. Fanconi anemia is a rare autosomal recessive disease. It is associated with bone marrow failure syndrome. It has variable of clinical presentations such as short stature, skeletal defects, microcephaly, café-au-lait patches, epicanthal folds, deafness, and mental retardation. It predisposes to various malignancies like leukemias and carcinomas. We have AML and MDS, and in carcinoma, it affects breast, genitourinary system, skin, esophagus, liver, kidney, head, and neck. My aim is to raise awareness for this rare genetic disorder, its familial and genetic counseling with prenatal testing, and its detrimental effect. Now coming to case presentation, my case is of a 10-year-old boy, resident of Sultanganj, who complained of fever, shortness of breath and weakness and mild chest pain for past 15 days. In past history, we found out he had delay in developmental milestone. He had bilateral club hands since childhood and recurrent UTI. In the family, he had asymptomatic parents and siblings, but parents had consanguineous marriage. In his complete blood count, we found out he had pancytopenia, of which hemoglobin was of 3 gram per dl, RBC count was of 1 lakh milliliter per mm3, and his total leukocyte count was 3000, while his platelet was 35,000. So in clinical examination, we saw the boy had short stature. He had severe pallor and he had bilateral radial club hand. He had absent thumb also. Otherwise, he did not have any organomegaly, lymphadenopathy, or any other significant finding. In imaging study, we saw a normal chest X-ray. In the X-ray of upper limb, we noticed that he had absent radia in the both hands and absent thumb. In ultrasound report, there was distorted pelvic calcium system and septations in urinary bladder. taking in account the following findings: clinical possibility of Fanconi anemia, TAR, PNH, dyskeratosis congenita, and Diamond-Blackfan anemia with Pearson syndrome was made. So we aspirated his bone marrow, and his bone marrow examination revealed a particulate hypocellular marrow with few lymphoplasmacytic infiltration. There were suppression lineage. His erythroid precursor was preserved, showing megaloblastic reaction. He had occasional megakaryocyte which had normal morphology. So keeping in account of clinical findings, imaging, pancytopenia with hypoplastic marrow, his chromosomal breakage analysis was done, which came to be sensitive for mitomycin C, and the final diagnosis of Fanconi anemia was made. Counseling his parents, we evaluated his sibling, who was a 13-year-old female. On examination, she also had short stature. She had absent bilateral thumb. She had a hypoplastic bilateral thumb. Her CBC also reflected pancytopenia. On bone marrow examination, her marrow was also hyperplastic. We did her chromosomal analysis, and it also came sensitive for mitomycin C. In follow-up, unfortunately, we lost the boy due to upper GI bleeding, but sister is doing well on supportive therapy. So in discussing this bone marrow failure syndrome, we have several causes of bone marrow failure, like Diamond-Blackfan anemia, which presents with congenital malformation, thumb, upper limb and craniofacial anomaly, dyskeratosis congenita with abnormal skin pigmentation, Fanconi anemia, which comes with developmental abnormalities, renal anagenesis and short stature, Shawman-Diamond syndrome, which comes with exocrine pancreatic insufficiency, and congenital megakaryocytic thrombocytopenia, which present with developmental anomaly. There is severe congenital neutropenia also, which presents with growth retardation. All of these cases either present with monocytopenia or pancytopenia. Fanconi anemia is a multigenic disorder caused by FANC-BA-CD1, in which FANC-B is X-linked, D1 is BRCA2 associated and predisposes to AML and MDS. Cytogenetic analysis may help in proper investigation and counseling. Other compounds sensitive is DEB and cisplatin. So cancer surveillance and education play an important role in management. Frequent CBC and HPV should be done to eliminate risk of cancer. Patients should be counseled for radiation and environmental risk factors. Hematopoietic stem cell transplant is only treatment, and consanguinity increases risk. Thank you.
Thank you. That was a very nice presentation. And I must congratulate you for adhering to the time. What is the commonest erythroid series finding on bone marrow in case of Fanconi anemia?
Sir, in early stages it presents with macrocytic RBCs, and later on
megaloblasts, right?
Yes, sir, megaloblast.
What all DDs can we have based on the bone marrow findings?
For pancytopenia, hypoplastic, sir, it can start from non-infective and non-malignant cause like like megaloblastic anemia. Then aplastic anemia. In infective, we have parvovirus B19 infection and leishmania. In storage disorder, we have Gaucher's disease, Niemann-Pick disease, and various storage disease. And in malignancy, leukemia can also cause hypoplastic marrow, hairy cell leukemia, and other leukemias can cause.
What is the mean survival of a patient of
So, mean survival is 20 to 30 years.
20 to 30 years?
Yes, sir.
Are you sure?
Sir, I have read in some.
Okay, thank you.
Thank you, sir.
डॉक्टर निशांत कुमार DMCH and अश्विनी कुमार पांडे DMCH आए हैं क्या? निशांत कुमार अश्विनी कुमार पांडे दोनों DMCH के हैं सर.
For their
लोड
presentation
कर रहा है
and
क्या?
finally we conclude this
मेरा
session.
लंच के बाद है, फिर भी इसको लोड करके हमको बता हो सकता है क्या किया है और कहे लिख के
A very warm good morning to everyone present in the auditorium. I extend my warm greetings to everyone here, and I expect everyone to reach the auditorium in a short while, as we are going to commence the scientific session very soon. In the meanwhile, I'd like to introduce the first speaker for the scientific session. That is Dr. Devdas Bose, who is currently working as an assistant professor in Institute of Hematology and Transfusion Medicine, Medical College, Kolkata. He did his MD Pathology from IPGMR, Kolkata, and DM Hematopathology from AIIMS, New Delhi. His topic for today is CBC and peripheral smear. So I expect everyone outside auditorium to please kindly join us, as we should start the scientific session on time. And for this session, as chairperson, I would like to invite Dr. A.K. Sinha sir and Dr. Shahi sir to chair the session. Kindly sir, please greet them with a warm round of applause.
नहीं है तो बाहर जाएंगे माइक है ना
Dr. Devdas. I'll once again introduce our first speaker of the scientific session, Dr. Devdas Bose, who is currently working as an assistant professor at Institute of Hematology and Transfusion Medicine, Medical College, Kolkata. He did his MD Pathology from IPGMR, Kolkata, and DM Hematopathology from AIIMS, New Delhi. Today, he will throw his enlightened views on the topic CBC and peripheral smear, which as all we know, for us pathologists, it's bread and butter. So sir, I kindly invite you to take over and enlighten us. Thank you, sir.
May I like to invite Dr. Bose, please. Please come on the dais.
Thank you, Chairperson, sir. Thank you, organizer, for inviting me. And thank you, Dr. Hashida Mandal, sir, for whom I came here. Thank you, my senior, Dr. Narendra Tejani, sir. He was my senior in AIIMS, New Delhi. And thank you all. So, we start with CBC. See, CBC is our definitely bread and butter, and we can diagnose many diseases in CBC. So, our point of discussion will be complete blood count, then peripheral smear, then retic count. These are all very important, and there are other associated tests like that test is to be done after examining CBC, so sickling and cytochemistry for leukemia. So what are the parameters in CBC? Usually CBC nowadays is done in your automated hematology counter. I think every lab in our India has the automated hematology counter. Okay, usually we used to do complete blood count with the automated hematology counter, and this is the counter generated your report. It has so many parameters. Okay, so it gives counts, RBC counts, hemoglobin estimation, WBC count, platelet counts. Okay, then indices. Indices are the usually derived, the RBC indices and platelet indices. Okay, and then reticulocyte count. Some of the high-end machine also give the reticulocyte hemoglobin also, and immature granulocytes. Immature granulocytes means in promyelocytes, myelocytes, and metamyelocytes. These are all comes in the IG, this immature granulocytes and NRBCs also. Okay. So we'll discuss in detail all these parameters. So this is the counter generated report, and you and pathologist has to verify it accordingly. Okay. So this is the counter generated report. So don't keep any report without verification. If there is any flag means if there is any abnormality, means this automated counter will show some star or some your hyphens. So this we call it as a flagging. Okay. So if there is any flagging, so don't give report as such. So you have to examine the peripheral smear and examine, just take a history and then generate the report. This report is signed by me. So this is the complete report. So you have to see in automated counter report what you have to see. First is you start with the WBC. WBC total WBC count, then RBC count, then hematocrit, then your MCV. Yeah, this patient shows the MCV is 63.4. So this is definitely abnormal. MCV is not normal. Okay, and then comes to the MCH. MC is also 29. MC is also 29 I think. Yes, 20. Okay, and your MCAC is not so much important. MCB and MCH is not so important, and the RDW. RDW is red cell distribution width. Red cell distribution width. Okay, so red cell distribution width is two types. We'll discuss in detail. One is your CV. CV means coefficient of variation, and one is SD, standard deviation. Okay, we'll discuss later on. Then comes to the your this is PDW. PDW means platelet distribution width. Okay, and then the MPV, mean platelet volume, and then your PLCR. PLCR मतलब platelet large cell ratio. PLCR, then platelet plate, NRBC, then absolute count of neutro, lympho, mono. Okay, mono, and your basophils and eosinophils. This is high-end machine. Okay, and this gives also IG, means immature granulocytes, reticulocytes. Okay, and different types of reticulocytes and reticulocyte hemoglobin. This all the parameters is given in your automated counter. Okay, then you have to see the peripheral smear and verify all these things with peripheral smear. Okay, so this patient showing your microcytic MCB is low, so we have seen it, and see the your these are the all histograms. So these histograms, WBC histogram usually is shows the your based on the your differential. This shows the your different types of your leukocytes. This is WNR channel, and this is W differential channel. We will discuss later. And this is your reticulocyte channel. Increased reticulocytes is there. Okay, and your RBC histogram shows more or less it's touching the baseline. We'll discuss later on. Sorry. And this is platelet histogram. So you have to, before giving report, you have to verify it. You have to see the peripheral smear. If there is any flagging, not even flagging, if there is any abnormality, you have to see it. Then sign out the report. Okay. So this is typical on your automated hematology counter. This is Sysmex counter. This machine we have Sysmex counter XN1000. So what are the principles of automated hematology counter? How it works? Automated counter usually works by three principles. It identifies cells as a size. Even some particles, it can identify some particles. So its size derived curves it produce some size derived curves. Then it differentiate different types of cells. RBC, WBC, platelets, okay, and different types of RBC. This is one is size differentiation. Another is count. It counts each and every cells. Okay, by your two different method. Okay, two different method. What are the different method? It it counts in your automated counter. One channel is there. So all the cells coming through this pore, and two electrode is placed. One is inside this channel, one is outside this channel. So all cells are usually not not conducting your electricity. So cells are usually not conducting electricity. So if one cells goes through this pore, so because cells are not transmitting the electric, so it gives one pulse in each and every cells. So if one cell pass through this pore, so machine gives one pulse. Okay, so one pulse means one event, means one cells. Okay, be it your WBC, be it your RBC, be it your platelet. Okay, so this is called electric impedance method. Electric impedance. So there is voltage difference between two electrodes after passing, during passing of these cells. So there is voltage difference. So it gives a pulse. So it is based on the electric impedance. Okay, one method is there. This cell is passing, and there is a difference between these two electrodes. Okay. Again, this is the same method. This one voltage difference is there. Another method is the radio frequency current. Radio frequency current, and one is the direct current. Okay, radio frequency current usually shows. This is the same thing. Okay, radio frequency current usually used for your measurement of the cell internal structure. Neutrophils have the much more granularity compared to RBC. So by radio frequency current, these neutrophils gives the different types of pulse than the RBCs. Okay. And direct current is the measurement of the cell size or cell volume. So two types of current, one is direct current, another is the radio frequency current. Okay, again, this radio frequency current, based on radio frequency currents, is shows the internal structure, and the direct current shows the size of the cells. So cells are differentiated according to the size of the cells, and cells are recategorized based on the internal structures. See, this pulse is being generated after getting all the cells. This pulse is generated. One line is means one cells. So pulse are generated. So histograms is available from this pulse. Each line is one cells. So different multiple number of cells machine counted. So your histogram is generated. Okay. This typical histogram. So there are many histograms. One is your RBC histograms, RBC and platelet histograms. And these histograms comes, as I told, based on the size. So this is also called size distribution curve. As the platelet has the much smaller size than the RBC, so according to size differentiation, platelet comes first. According to size differentiation curve. So platelet machine counts platelet from the 2 femtoliter to around 25 femtoliter. Okay. So 2 to 20 femtoliter is the machine count, platelet count. Okay. And RBC from 30 to around this 250 femtoliter RBC size. Okay. So and these lines are this is called lower discrimination line, because 2 femtoliter starting from here, this is lower discriminator, and this is the upper discriminator for the platelet, and lower discriminator for the RBC. Okay, and this is the upper discriminator for the RBC also. So we have seen the RBC curve, we have seen the platelet curve. So what are the abnormality we can get from this? Seeing, just observing the curve, we can suspect some abnormality. Okay, what are the abnormalities? See, in this curve, these platelet curves, initial curve is platelet curve and later curve is RBC curve, but this curve is not touching to the baseline. So what is the possible cause? This curve must start from the baseline, but curve not touching the baseline. So either this platelet size is much more, so large platelet or platelet grams are there, or RBC size are much more smaller, just similar to your large platelet. So there is either your mini large platelet or microcytic hyperchromic RBC, or there is your fragmented RBC. If there is much more presence of cystocytes, much more presence of microcytic cells, this type of curve we may get. Okay. another reverse is the RBC curve is not touching the baseline. This RBC's curve started from the baseline, but it is not touching the baseline. So what are the common causes? The common causes are because of presence of cold agglutinin. Now in winter session, you may get one patient with your blood clumped inside the vial. Okay, so this is presence of cold agglutinin. You cannot do your differential. You cannot put this even machine cannot do his work with the presence of cold agglutinin. So what we should do? We should incubate this blood in water incubation in 37 degree. It will this cold agglutinin will not work. Then put the sample in your machine. So machine will give the correct report. So presence of cold agglutinin, we can see this RBC baseline, the upper discrimination baseline is not touching the baseline. Okay, and presence of much more number of normoblasts, particularly in thalassemia. If you see transfusion dependent thalassemia, initially patient not transfused, but initially come to you with lots of normoblasts, usually your 100, 200 per 100 WBC normoblasts. This type of curve you may get. And another is see RBC platelet curve is perfectly okay, but RBC curve started from the baseline, gone upwards, then there is a hunch, double peak is there. So what is the causes of double peak? So two types of RBCs are there definitely. So if there is what are the two types of RBC? Because of normal RBC with microcytic RBC, or iron deficiency patient have your microcytic RBC, hypochromic RBC with patient getting iron. So sometimes and after getting iron, normocytic, normochromic RBCs are producing. So this produces different types of two different types of peaks, RBC peaks. And there is we are fascinating about dimorphic anemia. Any dimorphic anemia, your normocytic with your macro gives rise to this one, and transfusion also. Patient having your microcytic hypochromic, we are giving transfusion. Transfusion RBC is having normocytic, normochromic, so patient may give rise to this type of curves. Okay. Another is a cold agglutinin might give this type of also, because cold agglutinin may show presence of your baseline not touching. If it is gone upwards, then this type of curves may occur in cold agglutinin disease also. Okay. So, what is the importance of RDW? RDW. Okay. So, based on these RBC indices, what are the RBC indices? We have seen first. This is the MCV, MCH, and RDW, and usually MCHC. So based on these RBC indices, we can differentiate the anemia. Okay, everybody should we know because of your either microcytic hypochromic or macrocytic or normocytic normochromic. So what is the importance of RDW? Because most of the practicing pathologists used to see that most of the lab does not give the report of RDW. Okay, so RDW is very important. Based on the RDW, we can differentiate the different types of anemia. Okay, so what does RDW signifies? It signifies the different size of RBC. This is RBC anisocytosis, what you see in our peripheral smear. Okay, so RDW is machine derived. So what two types of RDW we have seen? One is your CV, coefficient of variation. Another is the standard deviation ST. Okay. So usually most of the lab does not give the report of RDW. Even if they give usually RDW CV, but CV is not so much. CV is popular. Coefficient variation type of RDW is popular, but it's not truly reflecting the anisocytosis, RBC anisocytosis. RDW SD is the much more accurate than the RDW CV. Okay, remember it. So how CV is calculated? CV is calculated just simple. Simple is calculated by the one standard deviation. RBC. This is RBC peak. RBC histogram. This area under curve with one standard deviation gives rise to the RDW CV percentage. Okay. This is L2 minus L1. This is upper one. This is upper size RBC. This is smaller size RBC. So this will be upper. So L2 minus L1 by divided by both. It's percentage. So RDW CV is percentage. Okay. So what is the normal range? 11 to 14 is the normal range. Okay. But RDW SD is see the RBC. This is also RBC histogram. What RDW CB is taking, this CB is taking the just your more or less uniform RBC from the midline. So we know from the midline to one standard deviation is around 68 point something, 68%. Okay, but RDW SD is taking the 20%, 20% with that 20% of RBC histogram is denoted by the RDW SD. Okay, so it is much more accurate than the RDW CV. Okay, much more accurate, but usually most of the lab does not give the RDW CV SD. Again, this is RDW CV and SD. So what are the then you go to the RBC curve also. So we have already discussed it. This RBC curve is not touching to the baseline, and now we come to the platelet histogram. Okay. So we have seen the platelet histogram. Okay. This is our first histogram. So this is your platelet histogram. Machine used to count platelet from 2 femtoliter to 25 femtoliter. So this is touching the baseline, and this is the RBC histogram touching the baseline. So we coming to the platelet histogram. So platelet histogram counted between 2 to 30. We have discussed it. Two flexible. This your discriminator is there. Machine will differentiate from this solid line to another line. This is the lower discriminator, lower discriminator. This is the upper size. This is the upper discriminator. So these are the flexible. Machine will count 2 femtoliter to 30 femtoliter platelet, and it will put this discriminator, it will count all the platelets. Okay, and another fixed discriminator at the 12 femtoliter. Here 12 femtoliter. Sorry, 12 femtoliter. This is fixed discriminator. Machine will count more than 12 femtoliter platelet. How many percentage of platelet having more than 12 femtoliter? Okay, usually normal platelet size is 2 to 11. Okay. Much more less, 1.4 to 3 or 4 micron. So, but machine will give your one beautiful report of PLCR. PLCR means platelet large cell ratio. Platelet large cell ratio. We call it in peripheral smear. We call it a giant or mega thrombocytes or giant platelets. Okay. So these are very important because in some disease we found the giant platelets present or not. If giant platelets are present, we know if patient is some patient has a bleeding with some child with a 3 years, 4 years, 6 years old child. We are getting so many patients, 6 years old child diagnosed suspecting case of ITP. We used to see presence of giant platelet because this giant platelet signifies that bone marrow is trying to produce platelet, and initial platelets are becoming large. So giant platelets are very important to diagnose a patient with ITP, at least by seeing peripheral smear, because in ITP we used to treat with patient with your steroid, and usually if it's a classical ITP, we don't do bone marrow upfront in our institute and everywhere also. Okay, if you are suspecting some acute leukemia, then you should do bone marrow. Okay, but based on this LCR, PLCR, we used to see, we are going to publish our report, findings in article. This based on this PLCR and your peripheral smear finding, we have found around 90% ITP can be diagnosed by seeing peripheral smear only and with your CBC count. Okay. So PLCR, if it is more than 12 femtoliter, so this is percentage of your platelet more than 12 femtoliter, it gives the PLCR. Okay. Another is the PDW. PDW is just like hematopoiesis. This is just like RDW. PDW platelet distribution width. The distribution again at the 20%. We have seen the in RBC also. In RBC also 20% is the RDW SD. In PDW also, this PDW also in 20% we have given the report of your what is the normal area 8 to 40. Okay, PDW. And what is the MPV? MPV is very important because MPV gives the average mean platelet volume. MPP is just like platelet kit, machine will measure each and every platelet, okay. So platelet kit is produced by platelet count. So MPP is the just indirect measurement in machine. So MPP is the normal 8 to 12 femtoliter. That's why machine given the your 12 one discriminator at 12. If it is more than 12, it will give the PLCR ratio. So what is the importance of mean platelet volume? Based on this MPV, we can diagnose on multiple disease viscoelastic. Viscoelastic syndrome is a rare disease, definitely rare disease, but we have diagnosed, we have at least suspected by seeing MCV, because MPV, because normal MPV is 8 to 12. If it is large platelet, it will machine will flag it. And in viscoelastic, what we have seen, I missed it. The counter report, because it's a rare, na, I have missed it. But we usually shows the hardly your 2 to 4, less than 8, definitely. We have seen 2 viscoelastic, one in names, or another in our college, but these 2 also give the less than 8 microliter. So based on this MPV, you should suggest the patient having viscoelastic or not, with your presence of your proper history. Okay, measured by same technology, dependent on the technique. And see, if we can diagnose aplastic anemia and ITP, usually by bone marrow, but in CBC and peripheral smear examining, you can diagnose this aplastic anemia. You can at least suspect this aplastic anemia or your ITP. Okay, so platelet count definitely would be less in both conditions. Okay, MPV is more or less normal in both cases. MP more or less normal. But see the PDW. PDW is definitely normal in aplastic anemia, but because presence of large platelet in ITP, because ITP bone marrow is trying to produce your much more platelet, and platelet being peripherally destroyed, but bone marrow is trying to platelet, so large platelets are producing, so there will be large platelet. So PDW will be increased. PDW means the different size of platelets. Okay, so PDW is definitely increased. So you can diagnose, at least suspect aplastic anemia from ITP by seeing the your platelet indices and PLCR. See the PLCR value. PLCR means large cell ratio. Large cell PLCR is usually up to 10 to 30% a normal value. 10 to 30%. So in aplastic anemia, bone marrow is not producing, unable to produce your platelet, so its PLCR is within normal limit. But see the PLCR here in ITP, because ITP is bone marrow actively producing, trying to produce much more large number of platelet, so it is the PLCR much more increased, more than 30. So ITP can be suggested by seeing your peripheral smear history and by examining your platelet indices. Okay, and see. What? Stop. And your what is the diagnosis of ITP based on this? What is the your sensitivity, specificity? What I told now that we need history, physical examination. Then we can see slide. We will see slide. First we will take the history. We will see the patient. Then we see the slide. So only your based on this CBC report and peripheral, it has very poor sensitivity and specificity. So only seeing this, don't keep suggestive of ITP, suggestive of aplastic anemia. Don't keep. Please see the patient, take the history, then you can suspect the patient might have ITP or aplastic anemia. Another your beautiful parameter is the immature platelet fraction. Immature platelet fraction. Okay, what is this? It's just like reticulocyte count. Reticulocyte count, just like reticulocyte is the immature RBC, and this immature platelets also fraction also, this platelet having your RNA material. Okay, so equivalent to retic count, enumerated after binding with dye, some polyethylamine dye. This all dye methane based, but every company has their copyright or the patent on that, so they are not disclosing which specific type of dye they are using, but usually dyes are polymethamine based. Okay, this IPF only available in Sysmex, but other Abbott and Abbott is also trying to give your also IPF also. So increase marrow production, IPF, ITP will be increased definitely. Reduced in aplastic anemia, just like bone marrow is cannot produce, unable to produce your new platelet, so ITP will be less. Okay, and it has some utility after post transplant. So see the immature red cell fraction, immature platelet fraction. If we see the immature red cell fraction, if you see the total platelet, see the platelet is here. If platelet is here, then these are the immature platelets. These are the immature platelets. Normal immature platelets is usually up to 6%, up 1 to 6%, normal. But in ITP see this portion is increased. This portion is increased. This is around 53%. So based on this year's IP wave and based on the other platelet indices, history, clinical examination, you can more or less confidently diagnose ITP based on these. Okay. Another important thing is the reticulocyte count. We all know reticulocyte count is much more handy in our new methylene blue or your another is or BCP, brilliant BCP2. But but nowadays everybody is busy. Some labs are overburdened with doing all these manual tests. So machine has come. So machine is giving your different reticulocyte count. So machine differentiate different reticulocyte count according to their fluorescence based on the your dye fluorescence. Okay, one dye again polyethylene based, polymethylene based dye. This reticulocyte is taking the different types of fluorescence. So this, if it is low fluorescence, this is most of the normal. This is normal one. Most of the reticulocytes are the low fluorescence. It around most of the reticulocytes. Only mid fluorescence and high fluorescence is 1 to 2%. Hardly, usually. But see the here. But see here. Here the reticulocytes. See this low, mid, and high. Okay. These are the other cells. Okay. See the your most of the reticulocytes are in the low fluorescence. They are very low in mid fluorescence or high fluorescence. This immature reticulocyte fraction is the collection of the mid fluorescence and the high fluorescence. Okay. So many slides are there. We have not started the morphology also. Please give me some time. And automated this DLC cutting machine give also automated DLC. It will discriminate lower according to size. This is lymphocyte peak. This is mixed peak. This is your neutrophil peak. Okay. And again, these are there are some lymphocyte abnormality. This is some neutrophil abnormality. Okay. See, these are the normal neutrophilia. This is neutrophilia. This is lymphocytosis. Because based on the size is smaller in lymphocytes, mixed. Then neutrophilia is the much more size. So this is increase of neutrophilia. This is lymphocytosis. You have to see on your machine. Machine has given usually laboratory technician used to take carb only for the no carb is taken. So you just order technician, just give me the carbs. So these carbs will tell you all the things. Okay. Again, all the abnormalities are there. I will be quick. And we will also give the NRBC scatterogram. NRBC scatterogram, these are the RBC ghost, this is the NRBC. So NRBC, how machine is machine count NRBC. NRBC cell membrane is lysed with stomalizer. Stomalizer we all know, have some lysis reagent with usually saponin soap based stomalizer is there. Okay, nuclear material stained with again polymethylene dye. Polymethylene dye based on the fluorescence. Based on the fluorescence, machine used to give your NRBC. Report of NRBC and immature granulocytes. Machine also counts, newer machine also counts the immature granulocytes. Immature granulocytes are the promyelocytes, myelocytes and metamyelocytes. Okay, because these your mature neutrophils have much more lipid content than the immature one. Okay, so machine by using during lysis the NRBC your neutrophils are lysed because much more your lipid content and lysis has soap type of chemicals. So these neutrophil lysis, but these immature granulocytes resist lysis. So based on this, the polymethylene dyes again your stains that your nuclear material, okay, nucleic acid, and by radio frequency or by flow cytometry based machine counts the immature granulocytes. Usually ADVIA machine based on the flow cytometry, and Beckman Coulter and Sysmex based on both your radio frequency and flow cytometry. Okay, this is IMI channel, immature channel. Okay. Then you have to do quality control definitely. Machine also can give the cystocytes also. Then quality control, at least you have to do quality control. Quality control material you have to purchase, but you can do quality control with normal sample also. Just repeat sample and other by seeing the LJ curves and X bar. It is available on all machines, all type of machines. Okay. So nowadays another machine has come, CellaVision. CellaVision is very grateful to pathologists because CellaVision can diagnose each and everything on its own. Machine does not need pathologist to give a report. CellaVision can identify every abnormality in RBCs. It can identify all abnormalities. It can identify monocyte, macro, everything. It can identify blast also, it can identify reactive lymphocytes, and Professor Sukesh Nair in CMC Vellore has standardized it, CellaVision, and they are giving excellent report based on this. Out of this, your 800 peripheral smear, they are seeing every day 800 samples, peripheral blood samples, they are seeing every day. Only 35 to 40 samples they have to see. Most of the samples is diagnosed by CellaVision. So CellaVision is if lab purchase one CellaVision machine, so he or she does not need any pathologist. So this is grateful to us, but we should know everything. So PS review is must. This the PS. See the different type of PS. This is normal, and this is some your polycythemic vera. This looks the density of the cells. Okay, so I will discuss some cases, 10 minutes only. Okay, so see the 6-year-old boy, just I will see the highlights the importance of the peripheral smear. Okay, these are all cases usually not diagnosed by doing all these things. We have diagnosed it by seeing the peripheral smear. So and these all cases come to our department in Kolkata. So see the peripheral smear. Is there any abnormality? Apparently there is no abnormality and our PGT release the report with a normal report. Okay. See, abnormalities are there definitely, and see the micro these are the polychromasia. Reticulocyte definitely increased reticulocytes, and during reticulocyte you should be aware of some your artifact lymphocytes might take the reticulocyte count. Don't keep it the type 1 reticulocytes. So reticulocytes is there definitely. So patient definitely have some your anemia with reticulocytes. Is definitely some hemolytic anemia is there. Okay, so and batteries of tests are there. But what we during my review we have seen lots of your cystocytes, lots of your spherocytes are there. Okay, so this is a classical history. 6-year-old boy, anemia, splenomegaly, lot of spherocytes. So this is a case of hereditary spherocytes. Hereditary spherocytes. The spherocytes are there. Spherocytes. Okay, reticulocytes. So we did your IOFT, incubated osmotic fragility test. Definitely red one is present, so increased osmotic fragility. Another repeated it. This March RBC osmotic fragility is increased. Okay, and nowadays all needs molecular, particularly clinical hematology is a very fond of molecular thing. So we did your EMA binding test. So EMA binding also shows the presence of your reduced binding. Okay, then the case number 2. See is there any abnormality in PS? Is there any abnormality? What are these cells? These sickle cells. These are all sickle cells. See, we did the sickling, the beautiful sickling test. So we did the HPLC. This is HPLC positive. This is increased, and the molecular test was done positive. With case number 3, 26 years female, admitted with jaundice, pallor, no fever, no hepatosplenomegaly.
reticulocyte corrected increase. So again, patient is your hemoglobin with corrected retic is high. So patient having definitely hemolytic anemia, and they see your bilirubin count is increased and LDH also increased. LDH is marked increase. So definitely patient having hemolytic anemia, but patient has little bit of lower increased TLC, platelet count is little bit increased, and patient having jaundice and pallor, no hepatosplenomegaly. Okay. So see what is this? This is a classical cystocyte. Lots of cystocytes. We diagnose this patient by seeing this patient. Actually, our SR, after passing your MD medicine, he used to practice in Howrah nearby station, and he referred this patient to me. Said we have some hemolytic anemia, nobody is able to diagnose, and by seeing the PS, and everybody in my colleagues are you're contradicting me. This is not a cystocyte. This is not your TTP. TTP cannot be diagnosed according to some hematologists. Particularly the older one, they does not know the cystocyte. This TTP can be diagnosed by seeing the PS only. So you have diagnosed by seeing the PS only. So this is a case of classical cystocytes, and patient was, after giving your 2 cycles of plasmapheresis, patient was okay. Then see this simple thing. Just want to mention this is the peripheral smear. See this is the end of peripheral smear, and see the RBCs. Okay, so this is classical case of, and see the 65-year-old low back pain for 3 months. We used to see if there is any chronic inflammation. We used to suspect this patient having some Roulet definitely is there. Roulet with this history, definitely multiple myeloma, definitely, usually. So different types of Roulet. Roulet, there is no definition of definition is there, but which part of the peripheral smear will you see for Roulet? So Roulet usually in thicker area will you see Roulet? No. So in thin area, if in your what is our workable definition is if there is if Roulet is seen within the one microscopic focus of the tail end. So if there is Roulet, so there is definitely Roulet is there, because in every slide you will see in thicker area there is a Roulet. Okay, so Roulet is there, lots of Roulet. So Roulet, so hemoglobin was low, increased creatinine was there. You have to know increased creatinine, high ESR, total count was little bit increased, little bit low. Okay. So your classical plasma cells. Okay, these are the plasma cells, 38 and laminar restriction. Okay, see this patient. This is interesting patient. See the peripheral smear. Out of these are the platelets. Okay, these are the platelets, but see all the platelets are much more. This patient was diagnosed in AIMS Neurology, not my patient. During my residency, I have diagnosed it. And see what of the MPB? MPB was flat. MPB is known. MPB was flat, but your PLCR was normal. So we have and patient has a history of bleeding. Yes. History of gum bleeding and epistaxis. Sorry, my spelling mistake. So yes. So this patient diagnosed having your Barnard-Solier syndrome, but we have suspected by seeing the peripheral smear and your CBC count. So another patient, this our senior will discuss this. This is this peripheral smear. So this type of cells. This is a classical case of promyelocytes. Classical promyelocytes. Promyelocytes usually people mistaken for the monocytes. Okay, monocyte. So these are the different types of promyelocytes. If usually the count is low, so see the peripheral tail end area. Tail end area usually thick, but see lots of promyelocytes. Okay, we did your bone marrow, and we did do your cytochemistry. Okay, cytochemistry Sudan Black is strongly positive. Promyelocytes and MP is the all the cytochemistry are positive. So I think we should stop here. Another 2 cases are there. Shall I continue or I'll stop here?
Stop. We are already stopped.
Okay. Thank you. Any question?
Thank you. Usually with the guest speaker in a conferences we don't ask any question because we have invited to it. But there is still I can give and I can request the audience that if any question is there, you can discuss it within the tea time with him. This is the usual culture. Usually guest speaker on the dais, there should be no question answer. If you have a question, when he is off the dais during the tea period, please ask him the question, whoever may be, and he will be pleased to give you answer. I think that...
Yes. Thank you so much. Thank you.
Thank you very much for your nice presentation. There are questions even from my side. There are questions, but it is a wrong tradition to ask a guest speaker on the dais. Right? Thank you.
Thank you, Dr. Devdas sir, for such an enlightening session. So please stay on the stage, sir, for felicitation. It'll take hardly 2 more minutes. So, not wasting much more time, I'd like to invite Kumari Anshika and Poonam from 2K18 batch to felicitate the guest speaker with a memento, shawl and a plant. Please come along.
बुला के फोटो ले लीजिए.
Thank you, sir. Now I would like to invite Dr. Shahi, sir, for the felicitation.
आपको क्या facilitate?
करना पड़ेगा सर.
करना पड़ेगा.
सुना तो बुला लीजिए.
एक kindly felicitate the other chairperson, Dr. A.K. Sinha, sir, for chairing the session. Thank you, sir, for your esteemed presence. I would now like to invite and start the second scientific session for the day. This would be a very renowned speaker in the field of cytopathology, Dr. Asitwa Mandal, who has been the National President of Indian Association of Cytopathology in the year 2006, National Vice President of IAPM in 2013. He has been President of West Bengal IAPM in 2014. He has publication, a repertoire of 182 articles in national and international peer-reviewed journals, and is a member of editorial board of IAPM and Journal of Cytopathology. He did his MD Pathology from PGI Chandigarh. Sir, please. For this session, I would like to invite as chairperson Dr. Satendra Kumar from Bhagalpur and Dr. Rajesh Kumar from Katihar Medical College. Sir, kindly grace the stage. Over to you, sir. Thank you.
दादा थोड़ा शॉर्ट कीजिएगा. आप 1 घंटे का टाइम है. You try to get it in half an hour तो नहीं संभव सर. कैसे हो? कर दोगे यार. हम चाहेंगे तो तुम. नहीं ये सर कैसे?
Good morning, everybody. Without wasting my time, I'll take permissions from the chairperson to start this lecture. This I have collected for last 25 years, sir. How can I finish it within half an hour? No. And all of you will enjoy because it is a clinical backup with radiology, with cytology and histopathology. So this is ये forward किधर है?
यहीं से माउस क्लिक कीजिए.
So the topic is diagnostic approach to pediatric non-odontogenic maxillofacial tumors. I am grateful to Bapcon for giving me the stage to highlight this topic. Now, in any diagnosis of maxillofacial tumors, three persons are involved. One is the surgeon or the oncologist. Next is the radiologist to know the site, size, and the lesion which is arising from the bone, soft tissue, or muscles or blood vessels, resectability, vascularity, necrosis. And it has tended to the clinical cytologist or oncopathologist to do proper biopsy and to give the confirmative diagnosis. So diagnostic approach, as we know, is for origin of tumor that can be done only by radiology. Next is proper site for FNAC for adequate representative material. This is for morphology, whether round cells, spindle cells, epithelioid, pleomorphic and mixed. Then for arrangements of cell, whether discrete clumps, palisading hole, glandular or rosettes, and background, whether it's tigroid, myxoid, nuclear or necrotic. So I think instead of going through these things, let us go directly to cases that will cut short the time. Mesenchymal tumors, I will start with the mesenchymal tumors. Now I want an interactive session. It's a child. How can you make out a mesenchymal tumor from an epithelial tumor? Usually mesenchymal tumor is intact mucosa. Mesenchymal tumors, lymphoid tumors have intact mucosa. Epithelial tumors usually give an ulcerative lesion. We can see a tumor arising from the buccal cavity going up to this part. See the involvement up to the orbit. Whole maxilla is involved and this is the tumor. If we see in the radiology, what we find that the tumor is in the maxilla is involved, orbit is involved, and also the base of skull and the infiltration to the surrounding brain. So this is the area we can see the brain is base of skull, brain, maxilla and oral cavity. Such an extensive tumor in a child. And this is the cells. What are the cells? Rounded cells discretely arranged. Vacuolar cytoplasm. We find vacuolar cytoplasm in Ewing's and also in rhabdomyocytes. So this is a child with a huge growth in the oral cavity, infiltrating maxilla, destruction of base of skull, with infiltration to the brain, with the round cell tumors arranged discretely, not much pleomorphic. And see, this is the vacuolar cytoplasm over there, and this is the cell block. Cell block we do from the cytology material, and we can see the mitotic figures, abundant, good amount of cytoplasm and prominent nucleolus. So with this we almost make a diagnosis of rhabdomyosarcoma, because the vimentin is positive, desmin positive, muscle actin positive, myogenin is positive. On the other hand, epithelial markers, lymphoid markers and CD99 is negative. So we have done cell block, muscle actin is positive, desmin and myogenin. This is, diagnosis is embryonal rhabdomyosarcoma, classical. This is a classical rhabdomyosarcoma. Now this is a child where you find that this is the tumor coming from the oral cavity, bleeding nose, swelling in the maxillary region, supraorbital ridge is almost full. So where is the origin and where is the extension? The tumor is coming from the oral cavity, you can see here, and this is the oral maxilla is involved, base of skull is involved, medial wall of orbit is involved, extension to orbit is also there. So this is a massive growth over the tumor, and if you see the cytology, these are the cells. It is highly pleomorphic. Can we tell it is a rhabdomyosarcoma or the anaplastic type of large cell LCL? We can also say large cell anaplastic lymphoma also. Same type of cells that we present over there. But the cells, but the child and the tumor, the extension usually tells it's not that type of tumor. The cells are highly pleomorphic. They are prominent nucleolus, good amount of cytoplasm are there, and mitotic figures. So this is the cells. These are the multiple tumor giant cells and highly pleomorphic nuclei, prominent nucleoli. Now this is positive for muscle actin, myogenin scattered and desmin positive. And what is the diagnosis? Embryonal rhabdomyosarcoma, anaplastic type. So one we have seen embryonal rhabdomyosarcoma, classical type, embryonal rhabdomyosarcoma, anaplastic type. And this is another patient. We will find that the huge mass coming from the nasal cavity. This is from our Calcutta Hospital, SSK Hospital, Calcutta, and it is they have done as biopsy, but almost all were necrotic because slough is there. There's huge bleeding from the area that what when FNAC was done, we get good amount of material. See, one nostril is totally blocked, maxilla is almost blocked, and there's a like subthalmus, the eye is coming from the outside. And this is the area where the nasal cavity are involved. And if we see on the more CT scar, we can see that the bones are destroyed. It has gone to the base of skull, and this is the mass which is coming from the outside the nose. So that's such a huge mass over here. And these are the cells, spindle cells. It is a spindle cells, highly cellular. The cells are pleomorphic. Round to over majority are spindle cells. But the material is, see how much material can we get in FNAC? Extremely cellular material. And these are the cells that you get spindle cells over there, and these cells, we did a cell block. Also the spindle cells, pleomorphic, and there are mitotic figures. These spindle cells, these are mitotic figures over there. And these are the positive for cytokeratin negative, not an epithelial spindle cell carcinoma, but desmin positive, myogenin positive. And this is diagnosis spindle cell adenoma. But usually we diagnose cases as malignant peripheral nerve sheath tumor or fibrosarcoma like glioma sarcoma. But this is not, this is a spindle cell adenoma sarcoma, which is a highly aggressive tumor in the facial-maxillary region. So if we see the varieties of embryonal, we have seen a classical case, we have seen the anaplastic type in a child, and we have just seen the spindle cell. And the solid variant is sometimes misdiagnosed with lymphomas. Lymphomas or the round cell tumors. Now come to the another. Is it a parotid tumor? See the very good facial palsy. This is the mass protruding the eye. Yeah, everyone is diagnosed it's a malignant parotid tumor. But when he did the FNAC, we found this is the cells. What are the cells? It's not a parotid tumor. We can see that the connective tissue strands are going. Cells are attached, some cells are floating, rounded cells. Not much pleomorphic. So it is not a parotid gland tumor. But if you see this is the icon, you can see the connective tissue strands over here and the cells. Some attached, some floating. And there are mitotic figures over there. So when you need the CT, we find, yes, it is not a parotid, but a soft tissue tumor. See the ear is protruded outside, and this is the mass. Bone erosion is there, but not much. It's basically a solid soft tissue tumor with early bone erosion. And these are the cell blocks. See how beautiful it comes. The connective tissue strands, we can make out the cells are rounded, prominent nucleolus, mitotic figures. So this is the cell block that we have prepared, and this is the desmin is positive, and myogenin is strongly positive. So, what is the diagnosis? Alveolar abdominal sarcoma classical. Now, this is the patient which created a lot of problem. The clinicians told us that it's a parotid gland tumor due from FNAC of the parotid gland. We, when examined the patient, that there is not a sort of parotid gland, but there is another mass. Can we see where is the another mass over here? Can anyone tell where is the mass? Apart from the parotid gland, but they were, the clinicians are very dogmatic, they do FNAC from the parotid. But we found a mass and still the parotid, what is the cells? Normal parotid gland. These are the normal parotid gland cells, this not, the tumor is not here. But where is the tumor? Now, is CT scan essential for FNAC of lesions of the parotid region? Definitely yes, in some cases to avoid false negative result. The clinicians may insist that the tumor is involving the parotid gland, but do not be surprised if CT scan shows differently. So we usually ignore any parotid gland tumor suggest to FNAC. But see the patient, this is not a parotid tumor. But if we have done the CT earlier, we can see that there is a mass in the parotid region with involvement of the soft tissue. Are pushing out, and there is also some bone destruction, and this is the cells that we got. See, where is the tumor now? This is the area. This is the swelling. It was extremely tender, and that is the importance of a clinical cytologist. When a cytologist do an FNAC, he has or she has to see the patient thoroughly. And if there is anything apart from the clinicians which you have pointed out, you should always tell that there is a lesion over there. And even if she ignores, you do FNAC as per his suggestion, but ultimately you will end up in problem. Until and otherwise, you take the help. So this is the patient. Parotid swelling looks like, but this is really is the mass. But where is the mass? CT scan shows this is the mass. Where is the mass? It is arising from the pterygoid muscles, medial and lateral pterygoid muscles. See the amount of bone destruction. This is a normal bone. This bone is totally eroded. This is a rounded mass. Huge mass in the base of skull with medial and lateral pterygoid muscle involvement, and FNAC was done is this. What is the cells? See, these are the difficult cases coming in FNAC. FNAC is not so easy if we do not see the patient, if we do not go through the records, if we do not know the CT scan, if we do not see the examines clinically, then we will miss. And this is the patient having nucleus which are wreath-like nucleus. What is the garland type of nucleus? Garland type of multinuclear. What are the cells of tissue tumor? We find garland type of nuclear arrangement in the tumor. Giant cells or wreath-like nuclei in the round cell tumors of a rhabdomyosarcoma in a child. Where do we find it? See the cell. This is the cells, and this is the cell block. See, beautiful cell block. They are same type, garland type, and these are the areas which show mild alveolar arrangement, which has come in the cell block, but we could not guide in the FNAC material. So this is the cells. These are the cells, and these are the nucleus, wreath-like or garland type, and this is the immunohistochemistry, which suggests that it's a muscle tumor, not an epithelial, lymphoid, or a round cell tumors. And myogenin is strongly positive, so diagnosis is alveolar rhabdomyosarcoma, solid variant. Now, the differentiation between embryonal and alveolar rhabdomyosarcoma lies in the sense that embryonal rhabdomyosarcoma is usually a strongly positive, and prognostically embryonal rhabdomyosarcoma is more favorable. So alveolar and embryonal, sometimes when they are solid variant, when the characteristic cells are not present, then we have to be very careful to stamp whether it's embryonal or alveolar. But this is the stain, myogenin stain strongly positive in alveolar, and in alveolar rhabdomyosarcoma we can find fusion gene. It is PAX3 or FOX10, FOX1 with PAX3 with FOX1 or PAX7 with FOX1. PAX3 FOX1 stain has a poor prognostic feature. Now this is another child. These all are presenting with facial palsy, but this is not parotid tumors. So this is another patient with facial palsy. And where is the tumor? The tumor is in the ear. We can see the fleshy mass over there. We did an FNAC from that mass also. And see, this is the mass. This is normal ear filled with air. This is the solid mass, and this is the bone erosion. And when we did the FNAC, we find this type. Can anybody tell the diagnostic clue of this type of tumor? Where is the diagnostic clue? Where is the cell which gives a diagnosis? Where is the cell that gives a diagnosis? This is the cell, tadpole cell. Tadpole cell. What are the tadpole cells are found? Squamous cell. Is it a squamous cell carcinoma? No. Is it a child with a ear mass, facial palsy, round cell tumors, rhabdoid cells? Where rhabdoid cells are found? It must be a case of rhabdomyosarcoma, one variant. Which variant? Rounded cells with this? We did a histology. Can anyone tell what is this layer? What is this layer? Which give you a diagnosis? What is this layer? Lining epidermis, lining epithelial, hypercellular area, and this is a hypocellular myxoid area. What is this layer called? That gives it a cambium layer. Where cambium layer is found? Sarcoma botrytis. And this is the area of hypocellular, hypercellular area, myxoid area. And this is very characteristics of your cambium layer. This if you find in any histology section, you can diagnose possibly it is a sarcoma botrytis. And these are the cells you can find hypocellular, hypercellular, myxoid areas. And these are the cells, very classical eccentric type of eosinophilic cytoplasm, rounded nucleus, and there is nucleolus is very small. Prognostically, this tumor is good, and this is sarcoma botrytis. And this is a tumor which is a variant of embryonal rhabdomyosarcoma middle ear, but mainly it occurs in the genitourinary tract, in the urinary bladder or in the cervical region. You have C hypocellular, hypercellular, loose myxoid stroma, foci of rhabdomyoblastic differentiation, which we found in the FNAC material, tadpole cell, cambium layer. So these are the characteristic finding of sarcoma botrytis. Another patient, where is that? See, these are the assets of FNAC. We do routinely breast mass, lymph nodes, thyroid, but these are the assets. Where is the tumor and what is the classical? Will the surgeon do surgery without a confirmative diagnosis? No. They do not know the origin, they do not know the site, how much is the extension, how much is the infiltration, whether there is receptibility or not, whether the tumor vascularity is not, nothing is known. They will not do until unless you give a diagnosis. And this is the tumor. See the extensive involvement. Maxilla, total area is destroyed. Orbit is all.
कोई बात नहीं आ जाएगा
मालूम है
स्क्रीन कैसे है?
आ जाएगा सर 1 मिनट
टाइम सर अभी 11:30 हुआ, 12 बजे तक तो देना चाहिए आपको, 1 घंटा
दिया सर रडार का 12 नहीं 12:05 थे
So this is the area, see the maxilla involved, the lower part of orbit and soft tissue involved. And this is the cells. See, the cytologists are blessed to give so much cells if we do the FNAC properly. So what are the components? We can find spindle cell, basically spindle cell. These are the blood vessels, endothelial cells, acellular collagenous material. And on Bap scale also you can find these are the blood vessels, acellular collagenous material, patternless pattern of growth. Where we find patternless pattern of growth, classical description is there. Patternless pattern of growth. In which tumor in the book we can find patternless pattern, this word is within the inverted commas. So CD34, now can we diagnose CD34 positive? CD34 positive, S100 neural out, SMA smooth muscle out, desmin skeletal muscle out, cytokeratin and EMA negative, possibly the synovial is out, but synovial BCL2 is positive in synovial. So is it synovial? Synovial will not give CD34 positive. Acellular collagenous material sometimes we find in synovial sarcoma, but CD34 is very characteristic of your solitary fibrous tumor. So this is a solitary fibrous tumor. You can see Vimentin, BCL2, CD34 solitary fibrous tumor. This is very characteristic. But when the tumor is excised, is such a massive growth, you can find that multiple areas of necrosis, hemorrhage, multinodular pattern is there. And if we do under histology, same time, the dilated hemangiopericytoma like blood vessels, spindle cells, acellular collagenous material are all there. And these are the areas where you find spindle cells, acellular collagenous and ectatic blood vessels. And this is, but when you do more sections, we can find that the pleomorphism and mitotic figures of the spindle cells are increasing. So these are the cells where mitotic figures are there, spindle cells are there, and diagnosis is solitary fibrous tumor with malignant potential. Solitary fibrous tumor with malignant potential. So it's not a benign solitary fibrous tumor, but a solitary fibrous tumor. Because this is a spindle cell tumor, head and neck region. Variable histologic appearance in a given case, so you have to do multiple sections from the excision. CD34 BCL to help to confirm diagnosis, but STAT6 IHC is sometimes required in cases of when the fusion gene is enabled to STAT6 fusion gene, because when there is a diagnostic problem with solitary fibrous tumor with other malignant lesions. And this is another patient, very fine, this is another tumor. And we can see this is the mass where the maxilla is involved, bone destruction is there. And this is another spindle cell. But what are the other cells apart from these spindle cells, rounded cells? What are these rounded cells? So lymphocytes mixed with spindle cells. So can you give a diagnosis of lymphocytes mixed with spindle cell tumor?
बोलिए भाई हम तो बोलेंगे लेकिन हम बोल नहीं रहे
So these are the spindle cells with lymphocytes mixed. So in cell block we can find these are the spindle cells, these are the lymphocytes. So anyone from this inflammatory myofibroblastic tumor. So you can find spindle cells and inflammatory cells mixed together. So histochemistry, this ALK1 is positive. ALK1 is very characteristic of inflammatory myofibroblastic tumor. So this is the tumor is excised from the maxilla. You can see this is the tumor, huge mass. But when you do the histology, you can find that there is a malignant, possibly malignant change, because these are the areas of multinucleated and these are the mitotic figures scattered, but the inflammatory cells are in the background. So inflammatory myofibroblastic tumor with malignant potential. So this is the importance of doing the excised specimens with glossing. FNAC can give a diagnosis, IHC can stamp a diagnosis, but whether the gravity of the tumor, whether it's a potentially malignant or highly malignant, we have to do the excised specimen with histopathology. So diagnosis is inflammatory myofibroblastic tumor with malignant potential. So can we label this tumor? A variant is known as inflammatory myofibroblastic sarcoma. So can you call this tumor inflammatory myofibroblastic sarcoma? Possibly no, because the tumor is ALK positive. ALK positive shows a tumor of low malignant potential. So this is inflammatory myofibroblastic sarcoma with malignant potential instead of calling a sarcoma of inflammatory myofibroblastic sarcoma. Now this is another. See, all these tumors are like facial palsy, but they are not parotid tumors. This is another patient, and we can see where is the tumor. Tumor is also in the ear. The patient came with bleeding from the ear and is plugged with a cotton. So clinical examination is very important. Where is the tumor? And you can see these are the patient, and this is the solid mass, but huge bone destruction compared to the soft tissue tumor where that bone destruction was minimum with extensive soft tissue. Here there is a huge area of bone destruction. And now, can we diagnose this case? Round cell tumor, rosette-like structures, discretely arranged. Very beautiful arrangement of homer-like rosette. Cells have vacuoles. What is this vacuole? Mitotic figures are there. What is this vacuoles? Filled with glycogen. PS positive, glycogen diastase labile. And this is PS positive. And see the histopathology. We can see that the CD19 and FLI1 is positive. And diagnosis is Ewing sarcoma. Now coming to the epithelial tumor, see that we can do FNAC diagnosis. This is the maxillary mass in a child. And when he did it, there is a mass in the maxilla. This is the mass. Orbit is the optic nerve. Orbit is involved. Round, and it's a huge mass. This is the well-delineated mass. This is the FNAC. Can we give a diagnosis of FNAC? These are the neuroblast-like cell with neurofilamentous structures with collections of epithelial cells. What are these epithelial cells? Along with neuroblast-like cells and neurofilamentous structure. These epithelial cells we can see in the high parts, the melanin-containing cells. Good amount of cytoplasm, melanin-containing cells, large cells, and these are the neuroblast-like cells found arranged in rosettes. So can we give a diagnosis of mixed neuroblast-like cells with neurofilamentous structures with epithelial cells loaded with melanin pigment? But what are the neuroblasts? Two populations of cells are there. Neuroblast is one component, but what are the epithelial components? Biphasic tumor, melanin-containing cells, abundant cytoplasm, pale nuclei, surrounding nests of smaller neuroblast-like cells with neurofilamentous structures. And the tumor was excised. And see, these are same type of cells that we got in FNAC. These are the neuroblast-like cells and these are the pale cells arranged in glandular pattern. And these have melanin pigment. If we go in other powers, we can see these are the cells are loaded with melanin pigment. And these are the neuroblast-like cells and these are the melanin pigment. So is it a malignant melanoma? Is it a neuroblastoma? Mixed. What is the tumor? What is the tumor? I have asked Tata Memorial Hospital, Dr. Roshan Senoy has told that I have seen only one case. At least I have seen 3 cases with 2 cases published. And what is the tumor? Very interesting case. See, this is the positive for HMB45 melanin. This is cyanotophysin positive, neuroblast. Diagnosis, melanotic neuroectodermal tumor of infancy. So this is the tumor which arises from the common site is maxilla, rapidly growing painless unencapsulated mass, locally aggressive, destroys bone. Neural crest derives neoplasm with two populations of cells, large cells, gland-like cell with gland-like areas, HSB45 melanin positive, small cells, synaptophysin positive, high urinary excretion of vanillic mandelic acid. You have to do VMA in this test because it gives prognostic characteristics. Now coming to lymphoid tumors. So this is a child with bilateral mass in the maxilla. Obviously on cytology we will give it, see the maxilla is destroyed and this is the mass over here. And we can diagnose it, yes. And if we go further, now can you diagnose it? Stamp diagnosis. Cells with dense blue cytoplasm vacuoles, lipid vacuoles with tingeable body macrophages with their ingested apoptotic tumor cells. What is the diagnosis? Starry sky appearance on histology. We can give a diagnosis possibly of Burkitt's lymphoma. So if we see these are the cells on histology, these are the classical of starry sky. These are the tingeable body macrophages. This is the these are the star and this is the tarry sky is caused by the deep blue cells and the pale staining histiocytes. And if we see FNAC biopsy, we can give a diagnosis. CD20 is positive, proliferative index should be as high as 100%, BCL6 positive and CD10 positive, and this is diagnosis of Burkitt's lymphoma involving bilateral maxilla and soft tissue. So this is a B-cell NHL, endemic type African, which involve jaw and facial bone, sporadic abdominal involvement with ascites, immunodeficiency, HIV and AIDS. They are all involved with the neural system, that is the brain is almost involved, CNS involvement, relation of Plasmodium falciparum, if there is patient having Plasmodium falciparum, endemic viral infection, Burkitt's lymphoma helps in the progression of endemic Burkitt's lymphoma. Lipid vacuole, starry sky is a benign histiocytes with apoptotic tumor cells are the stars, and the tingeable body macrophage, the deep blue is the sky, and growth fraction is almost 100%. So if we see the malaria, how it helps, that infected virus, B cells goes into the germinal center by the malaria, immunosuppression, and this malaria also helps in induction, that is activation into cytokine deaminase, causes the DNA damage and simic translocation, and ultimately gives to Burkitt's lymphoma. Now this is another tumor involving in the maxillary region. This is the tumor, and this is the area of involvement of the soft tissue, and this is the area. What is this appearance? Floating teeth. Floating teeth in a child. So this is the floating teeth, and this is soft tissue involvement over there. And if we give the FNAC, this is the cells. What are the cells? We find cells with groove nucleus, coffee bean type of nucleus along with the eosinophils in the background. So eosinophils in the background, coffee bean type of nucleus. What will be the diagnosis in this case? So this is the case of coffee bean type of nucleus with eosinophils in the background. Huh? Yes, it is LCH. And this is the tumor, and you can see. But where do we find coffee bean type of nucleus? In which conditions we can? This is very common questions in postgraduate students. Where we find coffee bean nucleus apart from LCH? Yes, papillary carcinoma of thyroid. Then Benner's tumor, granulosa cell tumor. Then highly poorly invasive duct carcinoma of pancreas and chondroblastoma. So these are the 5 areas where we find coffee bean type of nucleus. And what are the other characteristics of EM in case of LCH is bead-brag granules. There is a tennis racket, very characteristics that we find in cases of EM. So these are the cells. CD1A positive, Langerhans cell positive, S100 positive, CD60. Diagnosis is LCH presenting as a solitary osteolytic lesions. What are the type of LCH? Histiocytosis 6, and Sular Christian, literal 3, LCH is solitary, and also in Hashimoto Pitt disease, which is a congenital disease. So miscellaneous. Now this is the tumor, I think hardly anyone has got it. If anyone has got it, I will be very, very happy. What is the tumor? Smooth child, see, it's almost from birth. And it has been, see, this intact mucosa. Feeling look like a cyst-like structure. Is it an epidermal cyst or anything else? But when it did, and you can see the huge mass over here. And this is the FNAC. Yes, it is an epidermal cyst, mature squamous cells. But when you go more into this, these are the maturity is gone, but these are immature, malignant squamous cells are there. These are the cells. So what is this? Squamous cell carcinoma? No intact mucosa, cystic mass. The tumor is excised. Variegated appearance in the tumor. You can find solid areas, fleshy areas, hemorrhagic areas, all mixed together. And on histology, what you find? Teratoma. You can find cartilage, glands, blood vessels, muscles, bones, respiratory tract epithelium, squamous epithelium, and ultimately we find this is a squamous cell carcinoma mixed. So diagnosis is teratocarcinoma. Now the question comes, who will do the FNAC? FNAC will be done by a cytologist because of the ROSE-based rapid on-site evaluation. So this is the part where you find clinicians, radiologists, cytologists, oncopathologists, all should mix hands together to give a correct diagnosis. And cytologist is always at a risk because to save ourselves, we can always fall down if we do not take into account the patient's clinical history and the parameters, other ancillary techniques. Ancillary techniques is a must for a cytologist to do cell block, and on the cell block do IHC. And this is the gratitude that I am to show because I am invited over here. Thank you so much, sir, for this invitation. And with this, I finish my lecture. We will have an ACH conference in Kanyakumari in December 2023. I think many are members from Bihar in this ACH group. We invite you to go attend this conference. Thank you so much. Sir, I have 25 minutes, not in half an hour.
Thank you.
Privileged to be part of this session. If any interaction with sir, house is open.
Yes, sir.
No, sir. Your speech is enough.
I have seen you chairing my session also with Kisan. Yeah.
Yes, sir.
Thank you very much, sir.
Now I would like to invite Kumar 2018 girls to felicitate the guest speaker and chairperson, and thank you Asitwa Mandal sir for such a assortment of cases which I'm very sure many of our pathologists wouldn't have seen in all practicing careers. So sir, thank you so much for such cases. I'll invite Poonam Kumari and Kumari Anshika to kindly felicitate the speaker, Dr. Asitwa Mandal sir, with the memento, shawl and plant.
Please come in the center, sir.
सर थोड़ा साइड हो जाइए.
Especially brought from
Yeah, thank you, Poonam and Anshika, for facilitating our chairpersons, Dr. Satendra Kumar sir and Dr. Rajesh Kumar sir.
अरे वो लाइट हाँ बंद करा दो उसको हमारा का क्या हम लोड कराए
Let's go. Now, as we come to the end of the second scientific session, I would like to introduce our third guest speaker for today, Dr. Professor S.K. Shai sir, ex-head of Department Microbiology, IGMS Patna. He has also served as the Dean and MS of the same institute. He is the fellow of an Indian College of Pathologists and fellow of Indian Institute of Medical Sciences. Sir, kindly come on the stage and give us. He will be giving us an overview on basics of COVID-19. So I kindly invite sir to grace the stage. For this session, as chairperson, Dr. Kanesh Prasad Singh sir, HOD Medicine of Bhagwan Mahavir Institute of Medical Sciences, Pawapuri. Along with him, Dr. Mithilesh Pratap, HOD Radiology. Both of them will chair the session. Over to you, sir. Thank you.
Well, it is a good morning only. It's not a good afternoon, right? So it is before. I really appreciate Professor Mandal. Ideally, this was my request because the organizers are in restraint because they have invited the guests for the inaugural function, and I am standing here because I will help the organizer to finish the session at the right time so the guests should not be wait at the inaugural person. Inauguration should be done at the proper time.
Thank you, sir. Thank you.
If my chairperson allow me, then I will start. Okay, thank you very much. So, the talk is named as the overview and basic of COVID-19. Ladies and gentlemen, first I must tell you that the COVID has not gone. Yeah, with the effort of the Honorable Prime Minister and his team and all the medical people, we have been able to minimize it at a level where we are standing here in a safer side. Number second, that we have to be very aware and do that it can reoccur at any moment in a mutant form. I will be covering few things in a part, but I will restrict myself. My talk will be maximum 20 to 25 minutes. Though this talk was given to me at an international area where I spoke on this subject 1.5 hours. That was an Indian scenario. So I will short it and I will get it. Next slide please. Oh, yeah, second. You are seeing on the screen, it is a Yeah.
Pointer sir, वहीं पर. Yes.
COVID-19. I am audible? Yeah. Particularly with the PGS students, I am audible? Okay. I will request you to please hear it, because the things which I am going to tell you will be a very vital things for you in the Viva and practical examination, particularly in the Viva, the people will ask. This COVID, the word, this is the CO is denotes the corona. This is the VI denotes the virus, and this is the D denotes by disease, and 19 we got this epidemic or pandemic or whatever it is. I will be covering very shortly in a different heading, that is the introduction, epidemiological way, that is epidemiology, classification, virology, pathogenesis, sample collection, storage, transportation, lab diagnosis, and most important, how the variant are classified, what we work in Bihar, that in Indira Gandhi Institute, the COVID-19, particularly we went for the gene sequencing. That is the only center where we are able to do the gene sequencing. That data I will share with you. And lastly, how you will should control, prevent, and a few things, though I am not a clinician, but the clinician are here in the chairperson. A treatment, I will give you just a class. This is, in short, this is how the virus genome RNA looks. I will not go in details. The picture itself says you everything, that what are the things available in this. Spikes, envelope, nucleocapsid, hemagglutinin, and membrane. Though it is slightly boring, but I will tell you to hear it. If you go in a slightly, just 2-3 years back, then it can be tell that this coronavirus, COVID-19, is a highly contagious. I would use that is a highly contagious virus illness, cause severe acute respiratory syndrome, that is coronavirus 2, that is SARS-CoV-2, previously known as the COVID-19. The first case was predominantly a respiratory virus illness was reported in Wuhan. That's why we call it as and the American ex-president called it as a Chinese virus. So the Wuhan, Hubei province, China, in the late December 2019. And lastly, the WHO declared that as a global pandemic on the March 11, 2020. On 30th January 2020, the WHO officially declared this virus as an epidemic and a public health emergency of the international concern. This is a very few viral illness which gives the WHO as an emergency of an international concern. So this virus is in that category. We have few words in the epidemiological reservoirs and transmission. The bats, you must have heard, I will show you the picture, how it looks. It is a natural reservoir. Upon the virus genome sequencing, when we did it, and the scientists other part of the world has did is that the COVID-19, they thought that what is the reservoir and how these genomes are similar to those. Then what they found out that this COVID-19 was analyzed through the genome, particularly with the bad COVID, that is RTA-TZ13. It has shows 96.2% overall genome sequencing, it was equal. That was the remarkable thing. The human-to-human transmission occurs mainly between the family members. We all know, including relatives, friends intimately contacted with the patient in the incubation period. The transmission with ourselves, meaning by the health workers, occurred in 3.8% of the COVID-19 patients issued by the National Health Commission of China on 14 February 2020. Here, dear friends, I will ask you that this line which I have written, I think that this is not correct. This is not a 3.8%. it should be 93%. Because the transmission of healthcare workers are the people who are near to the COVID patients. So this is, in my view, it is goes to the 93%. Direct contact with the intermediate host animals. Consumption of wild animals are suspected to be the main route of transmission. However, whatever this tells the journal, it is the transmission route of this remain elusive because it is not confirmed. I will go to the next slide. This is a transmission cycle. This is just a demonstration that how the bats here, then the direct contact, then it goes to the intermediate host, then it goes to direct host. This is an incidental host, then droplet infections occurs, then this droplet goes to the human and the human transmission occurs. I told you just now that how it looks, there is a word note you must have read, that's pangolin. You must have also the bat to the mammal, pangolin to the human, November. It was discovered in the November, December 2019. What it is? Actually, this pangolin is a Chinese medicine. And this is linked with the seafood and exotic animal market, which was really was used in the China. And overall, on Wuhan, it might be possible that this Chinese medicine were used in the experiment and level 4 biohazard lab, which is that is a WHO funded things in Wuhan. It is a very big institute. So probably this is the root cause of the virus coming out from this Wuhan level 4 biohazard lab experimental and the animal source for the human consumption. Might be possible that this can be a link, but this is just a hypothetical question, but it gives a scientific proof also behind that. Again, in the epidemiology itself, the transmission is believed to occur in respiratory droplets. Analysis of the data related this in China seems to indicate that close contact are between the individual is necessary. It is correct in the Indian scenario also. Pre and asymptomatic individual may contribute 80% of the COVID-19 transmission. Spread is primarily limited to the family members, healthcare professional, and other close contact. Usually it is 6 feet, we all know, and or it is a 1.8 meter. Incubation period, there is a definite proof that it is a 3 to 7 days. And medium, if it is a 5 days, 5.1 day. The basic reproduction number, it is 2.2. In the other words, the average each patient's transmission this infection in the 2.2 individuals. अगर एक को हो गया तो कम से कम वो आदमी 3 को तो देना ही है उसको. And concerned duration of the contamination of the object of the surface, कहाँ ये रहता है? Again, then this you can find out whether on the plastic it is live up to 2 to 3 days. On a stainless steel it is up to 2 to 3 days. On cardboard it is on the 1 day, and on the copper it is up to 4 hours. This is a short graphical presentation that 2 to 3 days, maybe 4 to 9 days population varies, and probably twice the transmission as the influenza. I have compared it with the influenza because the influenza every year we see it comes and it infects a lot of people. But if you compare this transmission of the influenza, then it is more than 4.9% more than that. So you can imagine that how much contagious it is. Now, you must be knowing, and the people who doesn't know, they should know that how many coronavirus is found. Because we know only one, COVID-19 we call it. So it is actually a 7 human coronaviruses are there. 4 are normal and 3 are novel. Why we call it a novel? Because these are the notorious people, that's why we call it here, it is a novel. I will not go in details in that, I will come here only. That novel, there is a family, subfamily, and the genus, it is the alpha coronavirus, which is important, and this is the beta coronavirus, and this is the gamma. And this is the alpha, different nature, we have analyzed it, and this is the beta one, this is the, again beta one, this is the MERS. So, in short, what I told you, that it is a beta coronavirus, it is an enveloped and non-segmented positive sense of RNA virus. Novel beta coronavirus, which is show at 80% identity with that, which I showed you in the last slide. And on the sequencing, it is shown that the 2 pad derived from this acute respiratory syndrome, like coronavirus. This is at 80% identical. I will not go with this because you will not able to remember it. 80% identity to this and the 50% identity to this. This disease in corona-19 is a highly contagious. Again, I am dealing with the virus illness. Caused is an severe acute respiratory syndrome coronavirus, which causes nothing else but the death of the patient, which I already showed. This is short coronavirus structure. This is actually electron microscopic structure, and these are the details. This is the genome, what the coronavirus have. This is the S, M, and E, and H, E. This is nothing else. S goes for the spike, M for the membrane, N for the nucleocapsid, E for the small envelope protein, and He from the agglutinin, estrin, and the others. This is a single standard RNA. This is the different parameters, things which we get. I will not go into detail. You can consult with your book. Now in the book it is available. But this is an important one, that what are the things it consists. That's why I showed you in this slide. Again, the same thing. So this SARS-CoV-2 is similar to the typical COVID virus, contains at least 10 opening reading frames. The first ORF, this is the 2/3 of the viral RNA that is translated into the large polyproteins, that is the 1A and 1B. And this is the 2 important ones, the SARS-CoV and MERS-CoV-2 polyprotein, that is 1A and 1B, are processed by the 16 nanostructure protein from the viral replicate transcriptase complex. And 1/3 of the genome encode 4 main structure protein. From this is the last slide which I showed you, is the spike, envelope, nucleocapsid, membrane, as well as the senior accessory proteins with unknown function and which they do not participate in the viral replication. This is the genomic structure which you are able to see on this slide. This is come into the pathogenesis. Then how the coronavirus enters? The entry of SARS-CoV is by the direct fusion between the virus and the plasma membrane. This envelope which I showed you, is a spike glycoprotein binds to its cellular receptor, that is known as the ACE2 receptor. The attachment of the protein is spikes of the new coronavirus COVID-19 and SARS-CoV. I have a cellular attachment and factor, that is ACE2, this cellular protease, and this RSS2 for their activation. They are the responsible. Existing clinically approved drugs which we use are directed against this DRSS to inhibit SARS-CoV infected virus in the lung cell, which is very dangerous if the lung is involved. This is just a graphical presentation that how from the binding of the virus via entry of the membrane and the fusion. This is the second release of the viral genome. This is the third translation of the viral There is protein, this is the RNA replication. Like that, it goes and the disease occurs. This is the summary of the viral and host factors that influence the pathogenesis, which you see. I will not go in the detail because everybody knows even better than me. Then, the coronavirus entry and replication, should be known that critical proteolytic cleavage events occur. It occurs in the SARS-CoV protein at the position at S20 of this mediates membrane fusion and the viral infectivity that causes endocytosis and mediates SARS-CoV entry to the pulmonary epithelial cells. And after the entry, this RNA released into the cytoplasm, translated to the two polyprotein structures, and newly formed enveloped glycoprotein are inserted into the membrane of the endoplasmic reticulum of Golgi, and the nucleocapsid is formed, the combination of genome RNA and nucleocapsid protein. This is the real pathogenesis. Then these viral particles germinate into the endoplasmic reticulum Golgi intermediate compartment, and at least the vesicle containing the virus particles then fuse with the plasma membrane and they release the virus. During that, the human, our system are sensitized, and this antigen's presentation is done in the coronavirus. This antigen, this is nothing else but this is the antigen peptides are presented in the HLA systems complex, that is HLA in the human recognized by the virus specific cytotoxic T lymphocytes and the antigen presentation is this is in the SARS-CoV mainly depends upon the HLA, MHC molecules and MHA2 molecules that also contributes in the presentation. Coming to our own cellular immunity in the COVID-19, which is the most important one, that the antigen presentation subsequently stimulates the body humoral and cellular immunity, mediates by the viral specific. We know that the B cells and the cellular immunity is by the T cells. So, in the B cells, what we get is the IgM antibody, which usually disappear after the disease at the end of 12 weeks, at the 12th date. And while the IgG antibody, it lasts for a very long period and it may play a protective role, though we can't definitely tell, but it may play because it is said that the T cells, lymphocytes are the helper cells and it plays a protective role. This IgG antibody primarily it is the S-specific and N-specific antibody. In acute phase, that is the response to the patient's COVID virus associated with a severe disease, that is the CD4T and CD4H cells. Everybody knows that is what is the proposition and how it goes disrupted. This the above finding correlates with the lymphopenia which we see in the COVID-19 patients. Usually the low count we see that this is the mainly cause. So this is a graphical presentation, dear friends, is an antibody response to the SARS-CoV-2 infection. It is very easily you can appreciate this is the IgM, which I told you that it starts at 7th day and it disappears on the 21st day. In contrast, this is the IgG is detectable on the 14th day and it lasts up to the very long period. I think that I am clear. Okay? Right. Why? There is a very good questions are asked everywhere. That why some patients are in the 5 days becomes normal. Some takes 10 days. Some takes 14 days, 15 days, and some goes into the failure. What is the army wahi hai, same wahi hai, human response wahi hai. Then what is there are different things, but what is actually happens, which I want to convey you, that why few patients have a very severe and the fatal outcome in this viral illness. Previously, It was research shows that the HLA polymorphism correlates with this SARS-CoV-2 such as HLA-B 4601-703. Now the light has come. कहीं यहाँ ज्यादा देर लगता है
नहीं सर, वो चेंज कर रहा था, जनरेटर पे था।
वही है बिकॉज ये तो वीआईपी जगह है, आपको करना ही नहीं चाहिए सिंगल सेकंड।
करता भी नहीं कहा कि इमरजेंसी में लाइन
तो हम लोग कराए हुए हैं ना कि प्रेजेंटेशन चलता रहे, लाइट कट भी जाएगा तो ऑन ए बैटरी द प्रेजेंटेशन गोज ऑन, अपना लाइट आपका जाता है। So usually give you that this I already told you, and this structure information variation at this receptor gene have been studied to identify the susceptibility determinant, and it's postulated these AC receptors, these numbers which you will not remember, may confer the resistance to the SARS-CoV-2 infection. Now the next slide, which I want to show you is the real thing, that what it happens, that what are the risk factors of this. Everybody knows, but to summarize it, it is very common into the male in contrast to the female. But the females are also suffered. But largely the male are very. The next, it doesn't look like that the children are not suffered. But usually the older age people are, I am telling you that in which the more severe illness comes. So usually into the male, this is the older age people, and usually it has been seen the people who are suffering with the hypertension. This is the three article. I think that I am clear with that. If anybody, anything is more, then you can tell me. So if you summarize it, then it should be older age, more complication with the comorbidities such as cardiovascular and cerebrovascular disease, CKD, that is the kidney disease, with the diabetes, or imbalance between the two major RNA pathways, that is the AC receptors 1 to 7 and AC receptors and you is 2. Now, this is a very important slide. Two slides which are coming are very important. One is the interferon deficiency biomarkers of the patient, the risk of a severe COVID. This slide showed you only what a scientist. Actually, this is a key question which has been asked at a student level or the PG level that should be answered by me to know you, to improve the individual management in the prognosis of the patient. In a study which I quote, it is in the Science July 13 team by AP and HP intern, University of Paris and Institute of Pasteur and the Institute of Imagine describe a unique unexpected immunological phenotype in severe and critical patients consisting of severely impaired response of interferon, that is IFN type 1, associated with a persistent blood viral load and excessive inflammatory response. This data, IFN1 deficiency in the blood, could be a hallmark of the severe form of COVID-19, and it also supports the potential value of the therapeutic approach of the combined early administration of IFN with the appropriate anti-inflammatory therapy targeting IL-6 or TNF-alpha in a patient's preventing severe disease forms. I think the clinical people will tell more in that, but this is already This is a very interesting question which has been asked at the postgraduate level. That what is this cytokine storm? I heard so many times that this has been asked to the lot of places that what is that. Even I have asked at the postgraduate level, I have taken the class and I told them that these are the things which can be asked you and you should be very clear in that. I want to clarify all youngsters about this word cytokine storm. It is nothing else but it is the ARDS, that is the acute respiratory disease syndrome, is an immunopathological event of COVID-19. And one of the key mechanisms is ARDS, is the cytokine storm. It is nothing else but the deadly, uncontrolled systemic inflammatory response resulting from the release of large amount of pro-inflammatory cytokines, that is IFN-A, IFN-G, IL-1B, IL-16, IL-12, 18, 13, and TNF-alpha, and TGFB, etc. And cytokines CCL2, 3, 5, 18, 19, 10 by immune effector cell by SARS-CoV infection. This storm will trigger a violent attack